Hello, everyone. You're welcome to this MDC question style walkthrough. My name is Dr. Miranda Wozwame, and I will be taking you through this walkthrough. As always, during our MDC question style walkthroughs, what we do is to look at past questions and then use that opportunity to go into detail about the topic on which the question is centered on. Now, this question asks us to describe what we see. So we are looking at the image and asked to describe what we see. We are asked what is the most common cause of this condition in Ghana? What is the immediate danger to this patient and what must be done? We also asked what electrolyte abnormalities are associated with this condition and when is it safe to operate on the patient if an operation is needed. Now, what you must note about this question is that if you do not know what is going on in this image, if you do not know the condition that this image portrays, you will not be able to answer the rest of the questions. So, this is a great question for us to go through and understand. So, if we meet it in our exams, we will be able to answer. So, the first part, which asks us to describe what we see, this is what we see. We see an erect abdominal x ray showing centrally located dilated small bowel loops with visible plici secularis consistent with small bowel obstruction. So this image tells us that there is small bowel obstruction, and we will go into the details of what intestinal obstruction and eventually come back to explain why this image shows us that the condition we are dealing with is a small bowel obstruction. So don't go anywhere. Now, intestinal obstruction is a condition in which the passage of intestinal contents through bowel is interrupted, either due to paralysis or mechanical obstruction. We know that peristalsis occurs for intestinal contents to be able to pass through the bowel, but for some reason, passage of intestinal contents can be blocked, it can be interrupted. Okay, when it is interrupted, we call that an intestinal obstruction, and this usually occurs as a result of paralysis or mechanical obstruction. So we have seen and understood that mechanical obstruction and paralysis are the two major reasons why we have intestinal obstruction. But it is important to note that among these two, causes that fall under mechanical obstruction are the most common. All right, they are the most common. They are the most common reason why patients will come with intestinal obstruction. Okay, but let's tackle the less common one first. That is paralysis or functional obstruction. Now, what does the paralysis or functional obstruction mean? It means that the passage of intestinal contents through bowel is interrupted as a result of impaired motility or impaired peristalsis. Okay, so there is no structural abnormality that is blocking intestinal contents from passing through the bowel. There is no physical barrier. The issue when it comes to functional obstruction or paralysis is that there is impaired motility or peristalsis. Now, when it affects the small bowel, we call that paralytic ileus. And when it affects the large bowel, we call that a colonic pseudo obstruction. And usually in colonic pseudo obstruction, there is massive colonic dilation. So it's really massive. That is very characteristic for a colonic pseudo obstruction. So remember, it is called functional paralysis because there is no physical barrier, right? It's called a functional obstruction because there is no physical barrier. The issue that occurs in paralysis or functional obstruction is the fact that we have what we call impaired motility or peristalsis. Okay, so the bowel is no longer contracting and relaxing to allow intestinal contents to pass through. So that is functional paralysis. So, what is the etiology of paralysis or the etiology of functional obstruction? And the causes fall apply to both the small bowel and the large bowel. So, whether you have paralytic ileus or colonic pseudo obstruction, all of these can result in functional obstruction or paralysis of the bowel. So, when you have inflammation, okay, from either conditions like appendicitis or peritonitis, it can cause the bowel to become paralyzed. Abdominal operations, okay, due to the handling of the bowel during surgery, it can also cause this paralysis. Sympathetic hyperactivity, right? Now, we know that the sympathetic nervous system usually depresses bowel function. It inhibits peristalsis, while the parasympathetic nervous system promotes peristalsis. It allows for bowel activity to continue. So if you increase sympathetic activity, as seen in retroperitoneal hemorrhage and in spinal fracture, you are going to depress the function of the bowel. There will no longer be peristalsis. There will no longer be contraction of the intestinal musculature because you have activated or hyperactivated the sympathetic nervous system. Once you do that, you're going to depress bowel activity. Now, parasympathetic depression occurs when the parasympathetic nervous system is not working as it should. Because remember that the parasympathetic nervous system is responsible for the contraction and relaxation activity that happens with the small bowel. So if you depress the parasympathetic system, then bowel activity is not going to okay. And this can happen in electrolyte imbalances, like when there is hypokalemia, when there is sodium overload, all right. Metabolic disturbances like uremia and certain drugs like anticholinergics can also depress the parasympathetics. Okay, so these are the reasons why you can have a functional paralysis of the intestine, okay, or a functional obstruction which results in an intestinal obstruction. There is no physical barrier, but the motility of bowel is impaired either through inflammation, abdominal operations, sympathetic hyperactivity, or parasympathetic depression. Now, we've looked at paralysis or functional obstruction. Let's focus on mechanical obstruction, which is most common. Now, in mechanical obstruction, what you have is a structural pathology that blocks the passage of bowel contents. So there's something physically present that prevents bowel contents from moving. You see the difference between this and functional obstruction, where there is no physical barrier or structural pathology, just a problem with peristalsis or motility of the bowel. But in mechanical obstruction, what you have is actually a barrier or a structural pathology that blocks the passage of bowel contents. Right. So the causes can be grouped under three main blocks: intraluminal or within the lumen, intramural or within the wall, and then extramural, which is outside the wall. Now, in the lumen, you can have a foreign body, impacted feces, or helmintic infections like ascariasis blocking the passage of bowel contents. So this occurs within the lumen. Okay. Now, in the wall, tumors, intersusception, and inflammatory lesions can also block the passage of bowel contents. Then outside the bowel wall, volvulus, adhesions, and incarcerated hernia can also block the passage of intestinal contents. So these are the three main blocks that fall under mechanical obstruction. And as you can see, these are all physical pathologies that can block the bowel. These are structural, these are visible, these are physical, unlike the functional obstruction, where the only issue has to do with motility. All right. Now, what are the clinical features of intestinal obstruction? A patient will present with colicky abdominal pain, there will be vomiting, there will be obstipation. Now, I want you to take note of this word obstipation. Commonly, what the term that is used is constipation, but the most accurate term will be obstipation when it comes to intestinal obstruction, because obstipation is a severe form of constipation. With constipation, there is a decrease in the frequency of passage of bowel, okay, through the rectum. Whereas in obstipation, there is total absolute blockade, no passage of bowel, no passage of gas through the rectum. There's a total, complete constipation, if I should say. So that's what differentiates obstipation from constipation. Obstipation is a more severe form. There's a total blockade resulting in neither gas nor fecal matter passing through the rectum. Okay, you can also have abdominal distension, tenderness, guarding, and then decreased bowel sounds. All right. So from the question we saw, realize that that question was actually showing us that there was a small bowel obstruction. In terms of symptoms, how can we differentiate a small bowel obstruction from a large bowel obstruction? So, for a small bowel obstruction, because the site of the blockade is relatively high up and closer to the mouth, you have a relatively early onset of vomiting, which is bilus. Okay. While in large bowel obstruction, because the site of the blockade is further down from the mouth, the onset of vomiting is relatively late, initially bilous, and then progresses to fecal matter. Okay, because in large bowel obstruction, the obstruction is further down. So that is the difference you will see when it comes to large bowel. Now, Constipation, or more accurately, obstipation, is late onset when it comes to small bowel obstruction, especially when it is proximal, because the distance between the site of obstruction and the rectum is relatively longer. So beyond the site of the obstruction, you will still have bowel contents being passed from time to time until it finally collapses, as opposed to large bowel obstruction, where the distance between the obstruction and the rectum is relatively shorter. So, in a short period, the contents, the intestinal contents beyond the site of the obstruction is passed in a very short time, and then the patient begins to complain of obstipation, which is that they are not able to pass through or fecal matter. So they have early onset obstipation just because the point of obstruction is very close to the rectum. So when you pass intestinal contents out beyond the site of the obstruction, the onset of the obstipation is relatively earlier as compared to a small bowel obstruction. Now, in small bowel obstruction, the abdominal distension is relatively less severe, while in large bowel obstruction, the distension is relatively more severe because then again, the site of the obstruction is further down from the mouth. So there's a bigger surface area, there's more space for abdominal contents, for fluids to be sequestered in the abdomen. So the distension is relatively larger and more severe. What are the signs you would expect to see in a patient who has intestinal obstruction? There'll be dehydration, loss of skin tegel, okay, and all the other signs of dehydration will be present. There'll be visible peristalsis. In certain instances, you'll be able to hear high pitched or absent bowel sounds. Why do we have high pitched or absent bowel sounds? Usually at the beginning phase, at the early phase when the obstruction has occurred, the bowel becomes hyperactive in an attempt to force intestinal contents beyond the site of the obstruction. However, with time, this activity eventually stops and then bowel sounds become absent. So in the beginning phase, because of the hyperactivity, the attempt to force intestinal contents beyond the site of obstruction, you'll hear high pitched bowel sounds. But once this activity stops, as the condition progresses, bowel sounds become absent. And you may also see scars because the presence of a scar may point to the fact that an adhesion is the cause of the intestinal obstruction. So these are some of the features you may appreciate when you examine the patient. Now, what investigations do we do when a patient is suspected to have intestinal obstruction? Of course, you need to do your lab studies, blood count, your BOE and creatinine, blood grouping and cross matching, and your sickling test. And you may also you should do an imaging. Okay. Now we commonly do an abdominal X-ray, erect and supine as our initial modality. And also in low resource settings where there is no CT scan, you can rely on the X-ray, but the gold standard is the CT scan. It helps you to appreciate where the obstruction is and what exactly is causing the obstruction. However, if you're in a low resource setting, you might be restricted to doing an X-ray. You can also do an MRI and a barium enema. So, what are the radiological features that we see when it comes to intestinal obstruction? Once again, remember that our question showed us that there was small bowel obstruction. So, let's learn how we can differentiate between small bowel obstruction and large bowel obstruction on the abdominal X-ray. Now, your remember that the bowel, okay, is arranged. The anatomical arrangement is very characteristic. What we see is that the large bowel is more peripherally located. It's like a banner or a canopy. Okay. So if you pay attention very closely to this drawing, you realize that this is what the large bowel looks like. Okay. And then you realize that the small bowel is somewhere in the middle. Small bowel is somewhere in the middle, like that. Okay. So because of this arrangement anatomically, you can appreciate that on the abdominal X-ray. Now, remember that on the abdominal X-ray, when everything is normal, it's hard to appreciate the features of the bowel. But when there is a pathology, like when there's an intestinal obstruction, these features can be appreciated. Now, in small bowel obstruction, you'll see that there'll be centrally located dilated loops of the small bowel. So, because the small bowel is located in the middle, in the center, when there is an obstruction, you see that the small bowel will be found more within the center. Okay. And the measurement of the dilation is usually more than 3 cm. And you might see what we call a step ladder pattern. Now, a step ladder pattern is just multiple air fluid levels arranged on top of each other. And this is characteristic of a small bowel obstruction. For large bowel obstruction, on the other hand, remember, look at the way the large bowel is positioned. It's at the periphery. Okay, so when it is also dilated, you realize that the loops are located more at the periphery, and generally the dilation is usually more than 6 cm when measured, and then for the cecum usually greater than 9 centimeters. Okay, so that is the difference, one of the differences we can appreciate. We also look at the mucosal folds, and I will show that in the next slide. So when it comes to small bowel obstruction, the mucosal folds extend along the full width of the lumen. They extend along the full width of the lumen, but the mucosal fold in the large bowel, which is called the hostra, do not extend across the full width of the lumen. And in both cases, we have multiple air fluid levels. So in this image, which shows large bowel obstruction, you realize that the large bowel is peripherally located. There are dilated loops, okay, and when you measure, they should be more than 6 cm, okay, for the colon. But when it comes to the cecum, it can go as high as more than 9 centimeters. Then I spoke about the mucosal folds. We spoke about the mucosal folds. Now, if you observe very carefully, these are the mucosal folds, okay? They do not extend across the length, the full width of the lumen. It just starts and then stops. The mucosal fold starts and then stops. Okay, it starts and then stops. That is characteristic of the large bowel obstruction. We start and stop. Okay, if you come here, it starts and stop. It doesn't extend across the full length of the large bowel. Okay, and then of course you see multiple air fluid levels. It's not shown here, but generally that's what you see. So this is in contrast to small bowel obstruction, where you see that the bowel is more centrally located. There are dilated loops, and the mucosal folds extend across the full width of the lumen. They extend across the full width of the lumen. We call this the plici secularis or the valvuli conventus. Okay, so that is that. So that's how you can tell the difference between large bowel obstruction and small bowel obstruction. In small bowel obstruction, the mucosal fold goes across the full length of the lumen, whereas in large bowel obstruction, it's just a partial extension, just halfway through, just halfway through. Okay, so that's the difference. All right. So back to our question. So now we can appreciate why this question, when we describe this X-ray, we can accurately say that this is an erect abdominal X-ray which shows centrally dilated small bowel loops with visible plici secularis. So where the arrows are pointing, it shows us the visible plici secularis. And remember, the plici secularis or the mucosal fold extends along the full width of the small bowel. Okay, so this is consistent with a small bowel obstruction. Now, this question asks, what is the most common cause of this condition in Ghana? A strangulated external hernia has been observed to be the most common cause of intestinal obstruction, of which inguinal hernias are the most common. Okay, so just pay close attention to that. Now, when it comes to the immediate danger, as this question asks, what is the immediate danger this patient? What's the immediate danger to this patient and what must be done? Now, the immediate danger is that the person is at risk of shock. Okay, the person is at risk of shock. It could be hypovolemic shock as a result of the dehydration, the loss of fluid and electrolytes that occurs during intestinal obstruction. Because during intestinal obstruction, the abdomen becomes very distended. Okay, the patient vomits. When the patient vomits, the patient loses fluids, the patient loses electrolytes. And also because of the distension, there's a lot of sequestration of fluid. So the person, goes into shock because the person is hypovolemic. The fluid pulls into the abdomen. All right. And then because of the intestinal obstruction, absorption of fluids and electrolytes is also impaired. So it just remains within the abdomen. And it's very dangerous to the person and can cause shock. They also can have what we call endotoxic shock, which is a severe form of septic shock, because as fluid pools within the abdomen, it can lead to dilation of the lymphatics and translocation of bacteria into the circulation and can cause endotoxic shock, which is a very severe form of septic shock and is very dangerous to the person. So what should we do in this instance? We need to aggressively perform fluid and electrolyte resuscitation. We need to hydrate the person. Okay, we need to do a nasogastric decompression. And we also need to administer broad spectrum antibiotics to combat the infection to prevent the person from going into septic shock. So these are the interventions that we must undertake. Okay. Now, what electrolyte abnormalities are associated with this condition? So usually you can have hypokalemia, hyponatremia, and hypochloremia because of the intestinal secretions. The intestinal secretions are usually rich in potassium, sodium, and chloride. But because this is pooling and because of the vomiting, a lot of it is lost. Okay, and you can have these electrolyte abnormalities. Now, let's look at other complications of intestinal obstruction. We have seen shock, we have seen electrolyte disturbance, but let's talk about metabolic disturbance. In metabolic disturbance, usually when the obstruction is high up, when it involves a small bowel, the patient can have what we call a metabolic alkalosis. The reason being that in the small bowel, the intestinal secretions are usually acidic. So you lose a lot more of these acidic secretions because of the vomiting. And that tips the patient into a metabolic alkalosis. On the other hand, in large bowel obstruction, what you lose is alkaline secretions. So the person is tipped into a metabolic acidosis. We have already seen that there can be septicemia, okay, because of the bacterial translocation. And we also see that there can be renal failure. Why renal failure? The reason why we can have renal failure is because in renal failure can be caused by the acute kidney injury, either from the dehydration that occurs, the shock, and even the sepsis, okay, can shut down the kidneys acutely. So that's another reason why this is another cause of complication of intestinal obstruction, renal failure, either from the dehydration, the shock, or the sepsis. Okay, now when you look at the bowel itself, the bowel can become ischemic. Blood supply to the bowel is impaired. Okay, there can be bowel perforation. There can also be peritonitis, which are all detrimental to the patient. Okay, now this question asks us, when is it safe to operate on a patient if an operation is needed? It is only safe when you have aggressively done your fluid and electrolyte resuscitation. Aggressive because the patients lose a lot of fluids, they lose a lot of electrolytes. You can't go into surgery when they have fluid and electrolyte imbalance. When you have given antimicrobial treatment, you have put them on antibiotics, you can now go into surgery. You have to ensure that even in the presence of administering or having done your aggressive fluid and electrolyte resuscitation and your antimicrobial treatment, the patient's vitals must be stable. Stable vitals are very important before you enter the theater. Okay, we want to make sure that the systolic blood pressure is above 100, the oxygen saturation is okay. All the vitals are normal and within range. And you also want to make sure that the urine output is adequate because low urine output, anything less than 40 mils per hour, you will be dealing with an acute kidney injury, which may not be favorable when it comes to the administration of an anesthetic. It's very, very important that you ensure that the urine output is adequate. What happens after the operation? So usually the operation can be a laparotomy to explore and then relieve the patient of the obstruction depending on the cause. So post-operatively, you also want to continue to administer your IV fluids, continue to do your gastric aspiration, and also monitor the patient's vitals. Okay, you do this until on your examination, you are able to hear or auscultate bowel sounds, and the patient has been able to pass flatus. This indicates that the bowel has resumed its function, and now the patient can now start a light diet. Okay, so this is all for our MDC question style walkthrough. I hope it was helpful and I hope you learned a lot. You can head over to the MNEMOS platform, look at the surgical module, and you will find intestinal obstruction, where you can even learn more on the platform. So see you in the next one.